So thank you, Liz. So good morning, everybody. It's a nice morning. Talk a little bit about behavioral health issues. Okay. All right. So you'll see this is Kim Beach. You can see her. I don't know where she is in your Hollywood squares, but she's waving at you. She is from Demas. She's new to Demas. And we welcome her. So be nice, y'all, right? And she is going to join us today, and we're going to especially when we talk about where to sort of find the resources, what are some of the issues, right? So just as before, none of us are going to have all the answers right away. So Liz is happy to do a little research, as am I, as Kim, and so that's what we're going to do. Okay. All right. So the goals for the session are to, really frame the conversation about how to generate resources and opportunities for people with behavioral health issues. As a reminder, please turn on your camera. Please put your name in as you would like to be called. Remember, we also generate a sheet, a registration sheet from the people in there, and it comes from what you put in your windows. So be aware of that. We'll have materials on the BOSS website. We'll also put them in the chat. We love interaction. Just unmute and talk. You can raise your hand if you want. If you're more comfortable, you can put it in the chat if you're more comfortable, but feel free to just talk with us, okay? All right, so we're going to talk about different behavioral health conditions just to sort of get on the same page. We're going to talk about coordinating with community partners. We're also going to talk a little bit about crisis prevention and intervention, and then we're going to close it out. So as you said, eventually we're going to get a resource list from this. So it'll be based on the things you say, the things you need, that sort of stuff. So behavioral health issues, they bring their own set of challenges, but they also bring their own set of resources, right? Challenges can be surfaced in shelters. Challenges that behavioral health issues bring can also be surfaced in housing. Why? Because if you look carefully at behavioral health diagnoses, what they're based on is how does it interfere with people's functioning? So that's what we're going to talk about, if it interferes or if it doesn't. And that's a really key component. So everybody can think about, right? People in their lives, people that they've worked with who've had symptoms of mental health, of behavioral health issues, but really it didn't interfere, or they were possible to do what they wanted. Let me give you an example, okay? We had a woman live in our supportive housing in New York City. She had a fixed delusion that she owned the housing and several other things. She heard voices, but you know what? She'd heard voices for a long time. It didn't torture her. In fact, it kept her company. And she talked about it. And she said, I said, did the voices tell you to do something sometimes? And she said, sometimes they tell me jokes. So not being able to leave enough alone and being younger, we got her, she actually had a physical problem and they put her on medication and her voices went away.
This is Olivia. Who you want to speak to?
Okay, Olivia, I'm gonna mute you. There you go. So she actually was miserable when her voices were gone. She was lonely. And you know what? So what if she believed she owned the building, right? So what? She functioned pretty well. People really liked her. She had she was much more social. Do people have to be not psychotic? Nope. But people have to be able to pursue their goals, right? Right? And not have stuff that gets in the way of doing that. I'm not saying psychosis is a benign thing, but what I'm saying is everybody's different. And we don't want to assume that, right? Okay. So we want to look at that functioning. We also want to look at the resources that are uniquely available to people with a behavioral health diagnosis, right? Supportive housing. One of them, right? It's available to other people as well, but that will make people eligible. So there are different kinds of resources and there's different kinds of things that we're going for. Okay. Okay. Yeah. Why won't this work? There we go. All right. So we talked a little bit about psychosis. Psychosis is simply a break with reality. There are all sorts of things that cause psychosis, that underlie psychosis. Sure, it could be schizophrenia. It could also be a mood disorder, right? Could be a drug interaction. The person's thoughts and perceptions are disturbed, right? And they might have difficulty understanding what's real and what's not real. The way to work with somebody with a psychotic reaction or a fixed delusion or something like that, you guys know what that is, right? You've seen that before, is not to argue them out of their delusion. Right? Look, nobody's breaking into your apartment, right? So we, no matter how loud you say it, it's not gonna change their perception. The way to work with somebody with those sorts of fixed delusions is first to assess if there's a risk. And the other thing is to talk to them about the feelings. I see you're scared, right? How can we help you feel safe, right? Okay. Affective disorders are known as mood disorders, right? Depressive disorders, bipolar disorders, mania. They can, in the extreme, they can include psychotic features, right? They can be long-term, but they can also be situational. In this field, we see a lot of situational depression, right? So we want to take that into consideration. We need to consult with a clinician. We need to describe the symptoms well. So that's an important part that we've been talking about. When we're talking to clinicians or a psychiatrist, okay, y'all, full disclosure, I can't tell you how many times a psychiatrist has said to me, when you get your medical degree, come back and tell me that. And I thought, okay. So what I do is describe the symptoms. This is what's happening, right? You don't need a medical degree for that. Treatments are different. One of the things that's important to keep in the back of your head, though it's not so helpful to people in the moment usually, but that affective disorders are the ones that respond the best to medication. Or as psychiatrists like to say, affective disorders are the most treatable. So that's important to keep in your head, especially when somebody is in the depths of the depression, right? Is that we can get help for that. We also want to look for things that might put people at risk or the risk of crisis, right? An agitated depression is different than a long-term depression. You want to look for suicidality. If somebody is indeed bipolar and they have a mania phase, right? You want to look to see if that puts themselves at risk. That's usually more risky, right? Could include peer judgment and could include doing stuff. Sometimes it includes, buying everything off of eBay. Sometimes it includes going out and, putting themselves at risk, telling people things, that sort of things. There is often a substance use component, right? I am not going to introduce the sort of co-occurring stuff together with this. Sometimes people self-medicate, sometimes people do stuff, but most people, especially people who are having symptoms of behavioral health issues, right, will do some sort of self-medicating. Right? Okay. So let's think about this. There's another type of disorder that everybody complains about, so I'm getting it out of the way right now. And this is what's often called a personality disorder or borderline personality disorder. It affects the person's ability to regulate their emotions. These are the people that drive people the most crazy. So my differential diagnosis as a social worker was, if the staff comes to me and wants to hold hands and jump off the roof, in all likelihood, I have somebody with some sort of borderline personality disorder in the house, right? You see splitting of staff, you see people, their perception is often people are all good and then people are all bad. And look, let's face it, that's really tempting to a case manager, right? They say things like, you are the only person in my life that has ever helped you. Look, I was a case manager for a long time, and you got to admit, right? Somebody tells you that, and you, somewhere in the back of your head, you think, finally somebody noticed. It's a joke, y'all. Don't you feel like, right? They're very compelling. But if you're all good, you can also be all bad. So what I used to tell people is, if for the person's reaction is significantly different than everybody else in their life, the way they treat them, think about there might be something underlying it. Is it always a borderline personality disorder? No, right? But there's something different. The other thing I ask people to remember is something that's very compelling about somebody with this kind of personality disorder is that they feel empty and they create chaos around them to fill themselves up. So what I often relate to is how awful it would feel like being empty. It feels out of control. It feels scary, right? So there's a reason that people are doing this. It's not about you, it's about them. Oftentimes it goes with impulsivity. You can see some self-harm. You saw some cutting, right? They have higher rates of suicidality and self-harm than other types of the population. It lends itself to crisis, right? And so we want to always be doing a risk assessment, and our approach should be structured, which your approach is, right? So we want to focus on functioning. People with, symptoms of mental illness can stay housed, live full lives in the community. In others, their symptoms are the barrier, right? We want to focus on when the symptoms interfere with their functioning, make them uncomfortable, right? Because you know what? People change behavior, as in get some help, right? Because it's worth it to them. So for the purposes of rapid rehousing, we want to really focus on stuff that's worth it to them. We want to help everybody, meet tenancy obligations. In other words, we want to give them a structure to move forward, which is a key point of rapid rehousing. How do you move forward? You figure out how to increase your income. You figure out how to stay in housing, right? We want to give them the structure and something to compare it with. And we want to teach tenancy skills and, helping them increase their income, working on all the things that we would work with everybody else on, because these are key components of thriving in the community, right? And we want to treat the behavioral health symptoms as they interfere or as they make people uncomfortable, right? We also want to talk to people about the ability to get help that will enrich their lives. But usually in the beginning stage, and we always want to offer that kind of help. But what we're really focusing on is stuff that interfere with their functioning, present a risk, right? So that's what we're going to focus on. Does this make sense, y'all? All right. Is this what you wanted? Okay. All right. So we're going to try to make some of the connections, right? And we're going to make connections that are going to make a big difference in people's lives and are also going to help people function better. The other thing about the connections, especially treatment connections or support connections, is they have somebody else to talk to. And there are other opportunities to get services that they may need, right? So one of the key areas that people have really used is peer support services. Anybody here ever use peer support services? Are you using mental health peer support? Are you using them in your programs? Okay, so most CMHCs, right, have them as part of it. This is an example. It's just Yale Psychiatry. It talks about, how peer support is in clinics. They help people make connections. What?
Jason Tucker called in sick.
Jason?
Okay. There we go. They can provide support. They've been through the same thing, right? They are trained to work with people to increase their functioning. They provide an enormous amount of support. They also provide hope that they came through this and somebody else can. The other weird thing about peer support training and stuff like that is DEMIS actually provides a peer support training for behavioral health peer support. We actually encourage people to enroll in those trainings, and even if they don't become peer support providers, first of all, peer support providers are a good thing that people can work towards. And then a lot of people are interested in that kind of job. But the other thing is they teach those kinds of skills that will help them in their own lives. So I'll give you an example. A VA in, I don't know, Phoenix or something, enrolled all of their homeless clients into peer support training. And it made a big difference. There was also peer support lines. So things like warm lines and that sort of stuff, that can really be helpful. Is everybody familiar with warm lines? Do you know what those are? Okay. Warm lines are a line that's usually staffed by peers that people can call if they're feeling lonely or if they have an issue or if they don't rise to the level of the crisis line, but they want somebody to talk to, right? So it's something that you might want to consider. So look at NAMI's, DEMIS has a really good page on warm lines. Look up warm lines in your area, particularly look up hours. It can be really helpful. Has anybody ever used Clubhouse models? You know what those are? Clubhouses are recovery-based programs that are usually run by the people that participate. So they're member-based, right? They offer a range of services ranging from recreational to training to they connect people with treatment. Sometimes they help with housing. They also often have some sort of supported employment or employment that people can do. And they talk about, people living a full life in the community. It's often very helpful for people, particularly since people, as is recovery-based, they assume control of the clubhouse and what they're going to do in the clubhouse. People sometimes really like these, So this is just something on it. Yeah, go ahead, Alan.
Yeah, I just wanted to share that I worked with an agency that had one of these, and
Yeah.
it was life-changing for one of my clients who was able to work prior to his disability,
Yep.
and went into a severe depression, just all kinds of issues when he couldn't work. And
Mhm.
when he had this place that he would go to and do the work that he could do without doing too much, it was amazing to him how helpful it was in his recovery. So they are really amazing things, and I don't see them around much. But when I was starting out in my career, I worked at a place that had one of these, and it was amazing.
It's great. Was it in Connecticut, Alan?
No, it was in Indiana.
Ah, okay. So in New York City, the clubhouse model is Fountain House, right? And it is amazing to some people. Does it work for 100%? God, no, right? But it really is. And particularly, it gives people their roles back, gives them some control, right? It's recovery based. Now we call it psychosocial rehab, right? And people identify it's very goal based too, which is unusual, right? So if you go to the DEMIS website, they do have a list of those, and those are things we're putting together. Would that be helpful?
Andrea, I can't find the little spot to put my hand up. I don't know what's wrong with me today, but can I just add in, there's 36 around the state of Connecticut, so it is an available resource. And one of the great things is that you have to have a mental health diagnosis, but you don't have to currently be engaged in treatment. So it's a good kind of bridge scenario as you're explaining. It has that variety of resources, harm reduction, all of those different types of things. But because you have that kind of peer support and that network there, it's a good way for people to sort of start to learn about treatment if they're not already currently engaged.
Yeah, it's a great way. That's great. Thanks, Kim. Okay. There are other things that Kim mentioned. You have to have a mental health diagnosis. There's some things that we have to, that are specifically for mentally ill, right? We talk for people with mental illness issues. So we talked about this before. So I want to talk about, right, the thing that always comes up in this meeting, and I hope you guys are going to talk, right? You do not have to have an ICD 3-axis diagnosis to get into supportive housing. Bianca, want to say something?
No,
However,
I'm sorry, Andrea.
Okay. You do have to have a verification of disability, right? The other thing is if you're looking to see if somebody may have a mental health diagnosis, right? Something you can use, right, is something called a modified mini screen. Has anybody seen that? We actually use them in some of the mental health, the PATH outreach programs. And it just says the person may have symptoms of a mental illness. It doesn't, it's not diagnostic. It can be done by the person themselves, right? It's something you may want to consider because with supported housing, there are 3 categories that they will take people in. And it's actually the supportive housing to define it, but it's mental health, right? Behavioral health, it's HIV and AIDS, and it's substance use, right? And it's the need for long-term case management. So the modified mini screen may give you a direction. Is it required? No. So if I get a rumor out of this session that it's required, I'm going to come for all of you, right? But it actually gives people a lot of direction. So what I've sent to you is a training on modified mini screens, right, that we did for PATH, and also the modified mini screen. Is that something that's interesting to you?
We
No.
do the
Oh.
modified mini at Columbus House during the
Good.
intake.
So Leslie, tell us how you use it.
So some case managers will have the client complete it themselves, or
Mhm.
some will ask them the questions on there. And then depending on the score, we'll give a referral for mental health services or to our SOAR specialist to help them get disability. Or
Interesting. So you can get an idea about what people qualify for, and it's and if people don't want, I mean, I know Columbus House pretty well, so I'm pretty sure I know the answer to this. But if people don't want the referrals, right?
right.
Then one of the things you're cued on is just keep trying, right?
Yeah.
Keep offering.
Yeah.
It's great. Kim,
Found it.
you found it.
I just want to say again, because you are correct, that modified mini, of course, is not required. The piece that's required is the disabling condition verification form.
Yeah.
And what we really go by is the licensed professional who signs off on that form. So they're making
Mhm.
that determination through their interaction with the person, right? So that's the piece that is needed. It's important to make sure that when you're collecting that form, that individual does include their signature, their license number, the date, all of those types of details on that form, please.
It's really important. And people know the criteria for the verification of disability, right? It is somebody who is licensed to diagnose and treat the type of disability or the type of disability that they're doing. And it doesn't mean you have to have a diagnosis, right? By the way, when I was talking to Molly from Demas, she even told me that one of the things that can happen is that I said, well, okay, but permanent supportive housing is requiring this diagnosis. Say I have to have it to get it in the system. And she said, we have plenty of people who put in the system diagnosis deferred. And that's perfectly acceptable. So keep that in mind if you get any pushback, okay? Or call Kim or call Molly, right? Because Kim has been doing a dog and pony show for every COC, telling them that this is not required.
We've been going around to all of the CANs and working with our providers, just talking about these eligibility forms, all of those pieces. The disabling condition verification form very clearly says a diagnosis is not required on this form. If it's included in supporting documentation that's provided, that's fine. It's not, I mean, obviously we're not trying to avoid a diagnosis. It's just, it's not required on that form, and that diagnosis deferred is absolutely completely fine to put into DDAP, to put into the system. And then your notes can show that you're working towards connecting the person to services, potentially being able to update in the future with a current diagnosis, but that diagnosis deferred is absolutely 100% fine, yes.
So that's a big deal. The other thing that people have been using more and more is the mental health waiver programs. Do people know what those are? Mental health waiver programs are basically Medicaid, do they call them Husky waiver? They're programs that give people services in the community. People don't have to be homeless. It's out of the mental health system, right? And they can get them in housing. You can get mental health waiver services even in rapid rehousing, right? If people qualify. They have to have what's called an SPMI, which is a serious and persistent mental illness. You want to emphasize, recovery centered care. Okay. So this is something you might be interested in. We're happy to talk more about this. There were so many resources and so many things that related to the things that you've talked about. We want to give people a taste, and we want to hear from you what you want to hear more about. There is also a program, which I didn't even put on here, which is called ACT. Does anybody know what that is? It's called Assertive Community Treatment. There are assertive community treatment teams in Connecticut, right? There's one in every region or a couple in every region, and they provide, they go out, they provide care. They're more intensive. They're often referred to as a hospital without walls. So they include psychiatric services, they include employment services, they include social work services. They often include peer support. They're teams, and you want to find out where the teams are. In order to be eligible, you have to hit quite a high threshold, which is at least 3 emergency room visits or psychiatric emergency room visits in the last year, I believe it is, right? But if you look up ACT teams, that might be something that will provide support. It's going to be very rare, right? Because this is really the most intensive and expensive option. And it's reserved for people most in need. I think that if people are in rapid rehousing, it's probably unlikely they'll get ACT, but they could get ACT in supportive housing. Okay, just planting a seed here. All right. Mental health crisis was something you talked about, right? Are you guys just not talking today? What's going on? Are we hitting what you want?
Definitely are. I think we're all
Absolutely.
just pretty much taking notes as you speak.
Go ahead.
I am taking notes. I just have also been in this training a few times in the past few years with my past jobs.
Okay, in a mental health training. So tell me your name, first of all.
Bethany?
Say it again.
Bethany Maurice?
Okay. So, Bethany, what was most helpful about those trainings and what do you want to hear more about? And what kind of trainings were you in? Were you in mental health first aid? What were you in?
I had to do mental health first aid. I had to do a separate behavioral health training, and then I also had to do a de-escalation training. All
Okay.
separate, all
Yeah.
kind of touching bases on all of these, just going more in depth.
So what do you think was most helpful? And what has been most helpful in your work?
Honestly, those trainings were a little bit more hands-on because we were in person. So it was a little easier to get involvement from the audience because we were
Okay.
right there in front of them and we had like real life situations based on the type of jobs we're going into. I used to work with behavioral youth. So we
Yeah.
had those types of examples of, you know, what would you do in this situation and how would you necessarily handle this situation? So, yeah.
So we've got some small groups that it is in this, but that's very valuable information. So do you think it would be helpful if we decide how to narrow this down? We are just doing a broad overview today, right? So if we figured out how to narrow this down, would it be helpful to do an in-person training?
I definitely think so. If it's geared towards like the specific jobs that we all do, because I know that we all work in separate departments, but to get a more in-depth view on specifically homeless youth or, you know, like examples geared towards that, that definitely would improve my involvement. Definitely, I can't speak for others, but yeah.
You know, it's interesting because for homeless youth, and I know some of you work with youth, this is all geared to the case manager and rapid rehousing, right? So it's a limited time that you have to work with people, but it did occur to me that significant amount of the resources are divided between youth and or between families and singles. And it might be useful to do two separate ones, but I have to say that the cutoff for youth or children is children. It's over 18 that people go into the adult system, right? But it might be useful for some of the youth programs to talk about what really works in the youth programs.
Yeah, because even though the population I service is 18 to 24, these are youth that never really had much of a childhood, some of them, or they're coming out of a very turbulent situation and they don't really know how to manage it. And they're not thinking like adults. So I have to handle them a different type of way than I do my adult clients.
Absolutely. And it's a different resources may be different. And I'll give you an example, right? Is that sometimes when youth or somebody, let's say they're 20 years old, they've had their first break, right? They have some psychotic symptoms, but being with other people who have been having mental health symptoms for long periods of time actually scares them, right? So it may be a separate thing. So that's an interesting thing. So maybe we will do a separate one for the youth programs.
Thank you.
Of course. Tell us what you want, y'all. If we can figure it out, we'll do it. So we talked about talking about feelings rather than confronting delusions, right? What it looks like. I can see this is scary. It's hard to make a plan when you're so worried. What can we do to make you feel safer? That's what it starts with, right? Ask people what helped in the past. Look at their histories. Be structured, be consistent about what's acceptable. Let me give you an example. I don't know if you see this, right? But in supportive housing, we used to have a big problem with people. Sometimes voices get louder at night, right? Because there's less distraction. And we often had people who would make a lot of noise at night, who would be screaming to their voices or talking to their voices and would be up all night, right? We have to be clear that they cannot do that because they're disturbing other people. But we also have to talk about, right, what they're doing and how they can meet that need, right? So we may want to talk to them about, is there something else that you can do at night? Okay, you pace at night because it makes you feel more comfortable. Can we put a rug down in your room? We also want to think about low-tech options that might help people. Right? We want the structure. We want to identify what's interfering with the structure, right? Same structure as anybody else. And then we want to offer solutions that include treatment, but are not limited to treatment. Does that make sense? You want to offer resources consistently, knowing not everybody's going to take them. And knowing, remember we talked about this before. You ever get in a relationship with somebody that there were a few little things you were going to change, you wanted to change? How'd that work out for you? People change because they get something. It could be being able to stay in housing. It could be a girlfriend or a boyfriend. It could be any number of things. We want to identify those so people choose options. Great. People choose options because it makes sense to them. We also want to look at risk and imminent risk, right? So we want to look for things that are bothering them. People are looking for comfort or something that makes them feel better. That's fine. We want to work with that. People are looking to improve their functioning to get something they need or want. That's great. We're going to work with that. We're also going to look for, does this put them at risk? Which is knowing when to call for help. Let's be clear, nobody expects you, right, to provide therapy, or God knows, provide a medication or provide clinical services, right? Though the work that you do is very clinical, but it's not treatment, right? We want to make sure that you understand what all the treatment options are, as well as all the support options, so you can find the right option for the person that fits their need in the moment. Does this make sense? We always want to offer people an opportunity to get treatment because treatment can really change people's lives, right? But realize that that may not be their first step. And when people feel more comfortable and are more focused on what they need, they are more willing to try things. Does this make sense? Okay. You want to know when to call people, right? So we're going to talk a little bit about crisis. What's it mean for somebody to be at risk to self or others? At that point, we're going to intervene, right? So if somebody's at risk, an active risk to themselves or others, right? We're going to talk about it. If they are something called gravely disabled, unable to make decisions that help them, or that protect themselves, right? Give you a simple one. I've worked with many people who think they are being poisoned. So they stop eating. Sometimes they stop drinking. You try to work with them, right? but you need to decide at what point does it put them at risk. It has to do with weight loss. It has to do with a bunch of other things, right? But are they putting their life at risk? People who are suicidal, who may have a plan. Then we need help, right? People who are making direct threats against somebody else. We have a duty to warn, and we have a duty to get somebody evaluated, right? And remember, evaluation does not mean treatment, but it just means you're going to have somebody else's eyes on there about what the risk is. Can we talk about that for a minute? Have you guys been in those situations? So let's take suicidality, right? So what are the signs of suicidality? What are the signs that somebody might be gonna hurt themselves? Think about it. What are the things you would look for in the role of a case manager? I can tell you what I look for. If somebody's giving away all their stuff, somebody has drastic changes in how they're relating to people, they're saying goodbye to people, they say, you're not going to see me anymore. Somebody is talking about a plan to hurt themselves. If somebody has a means to a plan, if somebody's got a history of suicidality, of suicide attempts, that's going to really ring high on my risk. What do you do in those points, and how do you get people services? So have you guys seen any of that stuff? Come on, I know you've seen it. You guys asked for stuff on suicidality. We can, obviously, this is just the top of the, taking the top off, but think about it. Have you seen people who do those sorts of things? Rhiannon. Come on. Stephanie, what do you think? Is it coming up?
Hi, yeah, I mean, I've been working in this field for a while, so
Right.
I've definitely seen and worked with people that have been in these situations.
Mm-hmm.
You know, I try to talk with them initially, assess them, and then
Mhm.
offer them, you know, some sort of solutions, whether it's just a suicide, you know, prevention line, crisis line. I've talked with their families, try to get their families involved if that's at all possible. Sometimes it isn't. And, you know, try to look into their medical background, their mental health background, their meds they're
Yep.
taking. I mean, just try to get a good picture and then just try to, you know, address it accordingly, whatever the situation may be.
That's absolutely it, right?
Mhm.
So you're gonna talk about rallying resources, you're gonna talk about the history, you're gonna talk about suicide prevention lines, right? There's a lot of resources out there. Stephanie, what about a new case manager? What are the things that we tell them to look for?
Well, some of the things that you mentioned,
Yeah,
some of them aren't always so obvious though, but
right.
I would say even things like you can't get in touch with them, for example, you know,
Yep.
they kind of disappear. When maybe they made it through the intake, but then afterwards, you know, you can't seem to connect with them. And I think it's just always be aware of their behaviors, looking for certain behaviors, you know.
So would somebody bring that to their supervisor? Would somebody bring that to their team meeting? What
Oh,
would
I
they
see.
do?
Okay, I guess, all right. So yeah, absolutely, both of those things. Yeah, I would. I have.
Yeah.
Yeah.
And they're not alone. And you know what? Nobody
No.
expects you to have it perfectly, right?
Mm-hmm. Right.
There is a suicide screen here, right?
Mm-hmm.
which you could ask people, but it's delicate, right? And if you're not comfortable with it, don't do it. Get somebody else to do it, but you want somebody to do it, right?
Yeah. Yeah. And sometimes the client won't be willing to do those types of questions, questionnaires. They don't really want to admit it. Maybe they don't see it. Maybe they, it depends.
Yeah.
They don't
Andrea,
see
we
their
have,
behavior.
yeah. Andrea, I have Sue with a question and
Thanks,
then
Stephanie.
Rihanna. Yep.
Yep, go ahead. Who, Liz, who's the
Oh,
first
Sue,
person? Sue?
Sue, and then Rihanna.
Go ahead, Sue.
You're on mute, darling.
There we go.
No, my mic doesn't work. Go to.
Oh, that's okay.
We just heard you. Oh, whoops. Okay, so Rihanna.
I'm sorry, I was trying to get off mute earlier and I was failing desperately
You're
at
good.
it. So I think, yes, definitely, I would grab a supervisor immediately if you even
Yes.
think it's remotely headed towards someone being suicidal, because I think you always want the CYA thing, right? And you're gonna
For
wanna,
both you and the person you're serving, right?
yes, and I see it a lot where to be honest with them, all the way across, like we will tell them in sometimes in an intake, look, yes, you can talk to your caseworker, but if we think that there is a chance for you to harm yourself or others at any time, that's when we have to start making you a team, a supportive team. And we warm that conversation up, sometimes right in an intake if someone has severe mental health issues. So none of this is shocking that people are going to make a phone call to help you intervene in an escalated situation.
Yeah, and I mean, I think it is something we tell people in the beginning, and we tell everybody we work as a team, right? And that we share information as a team. And that sometimes as your case manager, I'm not going to be the one. And we want you to meet the team, right? And that we take things very seriously. Safety is one of them, right? And that also we can help people, right? So that's really important. Letting people know you're a team and using your team. Rihanna, do you have to be right? What
Nope.
if the client comes in and says, I never said any of that. I don't mean any of that. I don't want to do any of that. Sometimes as a case manager, particularly an early case manager, you want to be right, right? And somebody says that and you're like, oh God. But you know what? Better safe than sorry. Get somebody's eyes out on them. Offer people assistance in a different way. It's fine, right? Sometimes that just means that people have a plan, are going to move forward. We want to pay attention to that. Sometimes it means that they really were just trying to get your attention, right? Or trying something else, or they really didn't feel like that, or they just had it, right? But you know what? Those are things that we want to pay attention to, and we want people to get used to paying attention to, right? It's a lot of better safe than sorry.
Andrew, we have a question here. How do you properly support and or intervene with a client who is dually diagnosed and is exhibiting aggressive behavior?
Okay. So one of the things that we're going to do is we're going to use the structure, like what's acceptable and what's not acceptable, right? And those are general guidelines. So it has to do with the way people talk. It has to do with the actions that they take. We want to be clear about what's acceptable and what's not acceptable. And those should be something you talk about in your team and something under your policies and procedures. So what do you mean by aggressive behavior, right? It is never all right, right? You're in a case management relationship with people. It is never all right that people, threaten you or do stuff like that, right? And we want to get help immediately, right? if the aggressive behavior is escalating or if people need help, it may be an emergency situation. It may be the people are using substances and everything got worse. It may be a bunch of different things, right? And we want to err on the side of trying to get people an evaluation. It could mean that we call mobile crisis, which is a service that's available to everybody, right? So you want to have a relationship with mobile crisis and have them do an evaluation. Right? Oftentimes the line between criminal behavior and, behavior that, people exhibit regularly gets blurred, right? It doesn't mean if people are aggressive that they're mentally ill, and it doesn't mean if they're mentally ill, they're going to be aggressive or using substances and have symptoms of mental illness be aggressive. But if we do go into that thing, we want to rely on the structure. We want to be clear about what's acceptable and what's not acceptable, right? And we want to offer people evaluation, right? And in that case, a lot of times it's mobile crisis. If mobile crisis can't get out there fast enough, it's an escalating situation. We want to use, some de-escalation techniques. In some cases, we may want to get somebody transported, right, to a hospital, which can happen through mobile crisis. In some cases, we're going to use the cops or EMS, depending on the level of it, right? But because the cops or EMS take somebody in for an evaluation, doesn't mean they're going to be admitted, right? It may just mean they'll be held in the emergency room until everything calms down. That can often be frustrating, but that the symptoms have disappeared, so they can't really involuntarily hospitalize people. We've got to be clear about what the expectations are, and we've got to plan with people, right? The other thing is, particular people left on the streets, aggression can be the way that they establish boundaries. It may be something that's a pattern with them, and we want to teach them other ways to establish boundaries. If we feel at risk, if we feel they're at risk, if we feel they're putting other people at risk, we have to do something to get them in a safe, quiet space, right? Well, quiet emergency rooms are not that, to get an evaluation. Does that make sense?
Yes,
Kim.
and I also think too that it's important to tell the person who's having crisis that I think it's okay to be like, okay, we're not going to do this with this behavior today. We want you to get in another place, but that you want to see them again. Can you
Yeah.
come tomorrow?
Yeah.
Can you come back later on this afternoon when
Yep.
you've calmed down? And that sometimes helps us establish those boundaries of the behavior and when it's appropriate and needs to happen, and that we still want to work with you and solve
Yeah.
and do problem solving.
Absolutely. And you know what, Rhianna, I also want to say, just because somebody's taken to the hospital doesn't mean you don't go with them, right? You may not go with them in a car, but you meet them there, you want to offer follow-up. It's not like people are being rejected from services, but you're drawing a line for the behavior. Kim, you wanted to say something?
I just wanted to do another plug, Andrea, along the lines of what you were saying of mobile crisis really sort of promotes calling if you're not sure, even.
Yes.
Because it's better to call than not to call, and they can provide a lot of consultation. They can provide sort of alternative ideas. If it's not an appropriate scenario for them to come out, just they're available there. And then the other thing I just wanted to say, something that Liz and Andrea and I were talking about, is there is a centralized line for mobile crisis. There's 18 teams around the state, so it's fantastic, like you were saying, to have that relationship with your local team. But just keep in mind that there is that centralized number as well, in case you can't get a hold of your go-to person, or in case that connection isn't being made in that quick way. So I don't know if you want me to drop the number in there, or we'll definitely include it in the
Sure.
resource guide, something that we were.
Sure,
that we were
that's
chatting.
great.
Okay.
Yep. So that's really important. Hey, Kim, Molly had said in a discussion that Mobile Crisis has offered to do some evaluations for teams that don't have clinical staff, to actually do some call out valuations. Do you know about that? I don't know if that was something she had a discussion with a couple of mobile crisis.
I'm not sure. I'm not sure if she's in today. I can check with her.
Okay.
Um,
Yeah, we can check back too.
yeah.
But it may be the mobile crisis. Mobile crisis, I mean, Demas has heard what you're saying is that sometimes it's really hard to connect people with clinical services, and that there is an urgent care for families. People should know that. Sue, people are working with families. There's a behavioral health urgent care centers, but there is not one for adults. But mobile crisis has made some offers through Molly, and we'll talk to Molly and see if we can get some specifics on that. But that's really important. I really want to reiterate what Kim said. If you're not sure, call them anyway, right? You don't have to be right, y'all. And it shouldn't be, it's not a terrible experience when people say mobile crisis. We're offering people more resources, right? Okay. Kim has put them up. The mobile crisis number is in there. Okay. The other thing is you want to think about housing related crisis. And what I want to say here is that the structure of housing should be clear, right? We spent a lot of time on this. What are the expectations of tenancy? Nothing should be a surprise to people, so that actually the structure of housing helps us, as long as we have the information, helps us make a decision whether, be it substance use, mental health, whether it be orneriness, is interfering with them being able to meet the expectations of housing. And that's a problem with functioning, right? So we want to really maintain that base. Okay. All right. I'm not going to go. I went through a lot of these. All right. So we're going to try a breakout. Right? We're going to divide people up into groups. So think of a high-risk situation that's happened in your program. Could be in the area of mental health, or it could be suspected mental health issue. Talk about what led up to the crisis, what you tried, talk about what resources you used, and was there any other resources strategy that you think you would be using now? And are there concerns about accessing these resources? I'm going to leave this up. I'm going to give people 10 minutes. We're going to divide up in a group and let's see what we got. Does that make sense? Okay. Liz, can you put people in groups? All right. So remember, right? Affirmatively, check the box that you're going to join the group and let's try it. Welcome back. So what did you think? Did you learn new resources? Did you talk about the crisis?
We kind of monopolized the conversation in our breakout session.
Okay.
But we did get some feedback, so that was good.
So do you want to share a little bit about what the issue was?
It's a client that I had that I housed who seemed fine, and then she wasn't. She was very disruptive. All kinds of stuff going on, screaming, scaring people in the house.
Okay.
So I went over there with mobile outreach because I got a call during the day.
Great.
And when we got there, she was fine. Couldn't figure out why we were even there. Why did we bother? Like, what are you doing here? I'm fine. I said, well, it's about your safety. There was reports that you were kind of getting loud. So I don't know what's all that about. And she goes, no, I'm fine. I'm fine. So mobile out. And so, yeah. So, we left, and then, the same complaints are now coming. So, I haven't called mobile outreach, but it's reached a point now where they want her to leave because she's disrupting. Other people are afraid. They want to leave the house. So landlords asked for her to go. So I went over there, had a discussion. you know, she's not leaving, not on her own. Doesn't care if she gets evicted, so. you know,
So Chris,
that's
what did you try? What did you try in that case?
Well, I called, I let my supervisor know, but there's also people at shelter that specifically deal with this.
Yep.
High risk, whatever their title
Yep.
is. So they're all aware. So for right now, we're kind of in a holding pattern, you know, because
you
they
know
want
what?
her out. Yep.
You know what I ask people sometimes? Why do you think people are making these complaints? Why? Why do you think people are making
After-
these complaints?
After talking to her one-on-one about the fact that they did not want her to be there anymore, she became aggressive with me. So I see it. Now I see it, but probably 3-4 times I was with her, helping her move and all that stuff, got food. She was fine. No indication to me, but again, I'm not a clinician. I'm meeting somebody for the first time and, you know, she seemed fine, but I think it's really happening.
Yeah, okay. But she also has the ability to pull it together, right?
Yes.
So when you meet with her, she has the ability to pull it together. So maybe we really support those strengths about pulling it together, right? Explain to her the reason that people are concerned, right?
Yep. That was my last conversation, but I'll be honest, Andrea, during that last conversation, she got angry at me.
Yep.
And then it turned into, you're a liar, you're an F and this, the landlord's a liar, this. I mean, she got loud.
Okay.
And then made a comment at the very end that sounded threatening to me. So I wrapped it up, you know. I said, you know, you've made your decision. I said, if you need anything, you know how to get a hold of me. Have a good day. She laughed. You know, that's how it went. So it was very uncomfortable.
Yeah, it's not necessarily mental illness, but certainly it's a pattern that she's used before. And what we want to show her is that pattern is problematic, right?
Mm-hmm.
And then, you know, sometimes it is better to move people if you can move people, because sometimes they've absolutely burned the bridges. And then you want to talk to them about what they're going to do differently next time and what support they can get in order to do that. Because, you know, this person does have some skills and they can pull it together, right? But that you know, aggression is their go-to. That doesn't mean they're mentally ill. That doesn't mean it just means that that's where they're going, right? Let's try to figure that out. So sometimes talking to them about the next time and what they can do differently, sometimes is helpful, right?
I mean, she denies the behaviors happening at all. She doesn't know what we're talking about.
You know
So,
what? Behaving like that has worked for her in the past, right?
Right.
And I get that. I totally get that, right? So that, and I'm sure she was in situations where that sort of aggression kept her safe, right? So we want to eventually have a conversation about how else she can feel safe, how else she can feel in control, but just have the gentle conversations. And that, you know, it may have been too many bridges. And we didn't know about the behavior in the beginning, right?
No, not at all. Totally
So-
blindsided by that.
Scary.
Yeah, it is what it is. Thank you.
Of course. Other people want to have things they want to say. I want to say what Molly said to us during the break. Not Molly, Jesus, sorry. Kim said to us during the break. Kim, you want to talk about that, the LMHAs? This has been a big issue for people, so listen up, you guys.
I had to get back to my unmute button. Thank you. So just circling back to that disabling condition verification form, Andrea and Liz were sort of cluing me into the conversation that you all have had in the past, that sometimes it's difficult to find the right person to complete that form. So obviously you have those steps if you have clinical connections within your agency, if the person is already connected to a treatment provider, if there are systems in place, then those are the best places to go. But if you do not have access to that, we do have a list of people at each of the LMHAs that are sort of tapped to assist with this. I'm trying to get sort of in the background here a current list and see if that's something that we can distribute widely, or if it's just sort of something you would shoot me an email and I can get you the right name of the person that you're looking for. But we do have a list of identified people to assist specifically with these disabling condition forms to make sure that you guys can get what you need and get the person the continued assistance and support that you're looking to connect them to.
That's huge, you guys. Isn't that something that people were asking for?
That was
Yeah,
all
can you
Molly.
get that information sent to us? Can I get that information, please? Thank you.
Yeah, I'm trying to find out if it's a public list or if it's something that you would just contact me for and I can get you the information. I don't know. I have to get the current list.
All right, so then I guess I just need your contact information. I
Yeah,
wanna
sure.
follow up.
I'll
Thank you.
shoot my email into the chat.
Thank you.
You guys, we are going to, Liz, can you put the PowerPoint in the chat?
It's in there. It's in there.
Okay, okay. And so if you look at the front page, Kim's email is in there too. All right. We've talked about this a lot, and we're going to come through this again. This is connecting with community partners. We're coming to the end, so I'm not going to do this. You want to use clinical consultation. One of the things that we recommend to people is one of your team meetings does clinical consultation. It talks about issues that are coming up. You want to do it in a team forum so that everybody learns the resources and everybody learns the techniques, right? So problem solving as a group teaches people how to do it the next time. It's about mobile crisis. Here's the mobile crisis numbers, right? There is a mobile crisis for children and youth under 18, and there's one for adults. These are how you get it. This is an example of an urgent crisis center for children, but there are also walk-in centers for adults, right? That if it doesn't rise to the level of mobile crisis or doesn't rise to the level of, emergency rooms, you can use a walk-in center. We'll make sure that everybody has those contacts. Talk about mobile crisis. All right, now I have a question for you. If it is an emergency, then you call the police and EMS. So I'm not going to go through this point by point, but do people have policies about how you call EMS, emergency medical services, or the police if you're in a crisis? Does it tell you what to do? Does it tell you how to follow up? Does it tell you how to say it? Does it tell you in a crisis that you can release information such as what the behavior is and what kind of medication people are on? Does anybody here raise your hand or unmute? Do you have a policy that covers that? Stacy, did you want to say something?
No, I was sniffling. I didn't realize I was not muted.
You're fine. Do people have policies that cover this?
We do not. The only thing we have is what DEMIS requires, when we have any incident reports, whatever critical incidents that we have to report. But seeing this, I guess that, obviously that makes a lot of sense, and we will look at that in-house now going forward.
Yeah, and you know what? One of the things we can do in these meetings in the community of practice is that we can write guidelines for those sorts of policies if that would be helpful to people, because this is huge, right? Is you need to have their badge numbers. You need to be able to follow up. You need to know what hospital people are being taken to. You need to know what to do when people refuse to go. You need to know what the criteria is. And if you have them in policies, then people can do those things automatically and then really pay attention to the clients themselves. So if that's something you're interested in, think about it, because we're doing communities of practice, right? We can talk about some guidelines for what you do in these situations.
I would love the guideline thing so I can introduce that to upper management, because we do not have a company policy set for that, but the situations are excelling in numbers. Like, it's happening more frequently now where we're having to call between the shelter and our building. Anyway, they're two separate buildings where homeless prevention program is, and then the shelter is right around the block. And it's excelled to where we've either had to call the police or EMTs.
Okay. So let's get some guidelines for policies and then we can do it, right? Would that be helpful?
Yes.
Okay,
I think it would be helpful as well.
okay, great. Okay. Okay. Oh, there we go. These are some intervention cases, but I am going through these more quickly because I want to hear from you what would be most helpful. So as you hear, when we're going through this stuff, we're introducing some resources, right? Like we agreed to, we're going to try to come up with a resource guide, but we need to know what's most helpful for you guys. Look, I realize that having a resource guide that's 22 pages is probably not going to be the most helpful thing to you. So let's prioritize what would be most helpful. So we got big reactions to that VOD thing, that who will do that. We got big reactions to a bunch of other things. So we're going to put those in there. Is there anything that we didn't cover that might be helpful to get the resources you need, right? Because I'm hearing from you guys that you're seeing people who are having more and more, showing more and more behavioral health symptoms, or what you see as behavioral health symptoms. How can you get help for that, right? How can we get help as early as possible? So whatever point it is we want to talk about, but what would be most helpful to you guys to see? Do you have people in some situations, and I want to encourage you to talk about this in the community of practice, in some situations where it may not be a crisis? If the crisis is what you want to talk about, we can do that. But if people are not in a crisis, this is always was my biggest thing to figure out. People are not in a crisis, but you want to get them help or offer assistance as early as possible. What do you need? Come on, you work with these guys every day. What do you need?
We need them to go.
Well, you need them to go through rapid rehousing, right? So,
Well, or we need them to agree to, because we're getting a lot of severe mental health issues with absolute refusal to meet with them. So we can't even get them for an evaluation.
okay.
And so
We
the
need them
thought
to go
of
to the
housing them,
evaluations.
yeah,
Okay.
the thought of housing them is seems like an undaunting task, for one. For two, so they're sitting in a shelter bed, right? And the wheels are spinning, and we keep trying to introduce that and meet with them, and it's severe mental health. And they will not meet with anyone to even begin to have a conversation about having a mental health provider. And then we worry about putting them in, especially the youth, in a room rental. We worry about them upsetting the rest of the tenants in the room rental situation. And are we going to alienate another landlord with a person who is refusing the mental health crisis? But Housing First tells us we have to house them and get them in and then address those needs. But we don't want them to burn bridges for themselves or others on the way in. And so it's trying to be that boundary, that boundary line that cushions all of those sharp edges and make it all happen. And I know that personally my staff is really struggling with that right now on a couple different points.
So one of the things might be another housing problem solving conversation. And it really being clear that rapid rehousing may not be the best option for people because of the level of case management, right? That also means that when people are sent to supportive housing, that we're sending people to supportive housing, not just based on a VOD, but based on the fact that these are people that need long-term case management services. So maybe doing more of a differential, right? So that's part of it. That's a system issue. But part of it is also maybe working with people in shelters, and also when you're doing the pre-rapid rehousing, is talking more about how to motivate people to seek out behavioral health services or allied services that might help with what's being seen as a behavioral health crisis, right?
Yeah,
Okay.
I'm piggybacking off of Rhiannon just because she is my supervisor. We had a conversation on Friday about, I have one youth in particular that's been at shelter, just kind of swimming in a sea of very not like lucid thoughts but doesn't see anything. Just to her, she doesn't have any mental health. Like the celebrities in her head are really in her head. And now I'm tasked with trying to come up with a long-term housing plan, and I'm hitting the same wall that Rhiannon was just speaking about, because it's like, yes, we're housing first. Yes, like I don't want anyone to be in shelter, right? None of us do, but it's now, I just got a phone call from her that I wasn't able to take, but if she's now disrupting the space and the safety of others, maybe not physically, but verbally, she's continues to escalate. And then it's like, well, why has she been here so long? Why isn't she housed? It's tough to house someone when they don't want to meet with me because they're meeting with the cast of Jersey Shore in their head. But mobile crisis, they present well enough that mobile crisis won't take them.
That's
so
what
where
that's
I'm
what I was
stuck.
looking for. So how to motivate this person for treatment? It goes to both resources or assistance, right? It doesn't have to be treatment. It could be support. It could be a bunch of things. Stacy, have you ever heard of these first break groups?
I have not.
Okay, so first break is when one of the things that the research tells us is when people first show psychiatric symptoms, right? Psychotic symptoms. It often happens in late adolescence, early adulthood, right? So it's right where you are, right?
Right. Yeah.
And they have specific programs for people who are in a first break, which tends to be older and tends to be oriented towards the needs of youth. So we can certainly get you those resources, but it might be a discussion about how to use those resources. Oftentimes, look, I remember when I had somebody who was very young, was 20 years old, and had their first break. And they had been recommended, I was in a shelter, they had been recommended to go to something called a community residence. And most of the people in there were older, and a lot of them had been on long-term psychiatric meds, and the person went in there and freaked out, right? And that was their impression of what psychiatric services are, but they're not anymore, right? There was a time when they were, but they're not anymore. And I think that that's one of the reasons why I was thinking about separating youth. These first break programs have been really successful, right? There are also programs that are geared at the sort of what they used to call negative symptoms of psychotic disorders, but also other negative symptoms, which is called cognitive remediation. And that's available in Connecticut under behavioral health. And that helps people focus. It's video game based.
Huh. Okay.
And it helps them improve their skills, their organizational skills, which is what you're describing. So this is a very pinpointed thing. And I think we can do some of that in the communities of practice, but it also really reinforces for me that though cognitive remediation is useful for adults, we use it a lot for adults, but it's really useful for youth too. So it may be a separate thing for youth, right?
Right.
But these
And I
first
often
break
will come back
programs-
to Rhiannon after a meeting with a youth, and I'll, give her I'll debrief with her, and then I'm like, well, this is their age, but mentally they're probably between like 14 and 16. Like they're not really 24. So you have to then get creative with how to approach things and how to kind of
Yes.
coach and guide in a way that's not, you get what I'm saying.
They're missing big things. I just want to say that things like organizational skills, focusing skills, task prioritization, task follow through are all developed in late adolescence, early adulthood. And my impression is everybody should get that cognitive remediation training who works with youth, because they're really useful ways to teach those sorts of skills. And that for adults, we see it too, because they were compromised in late adolescence, early adulthood, right? By all sorts of things, homelessness, right? All sorts of things. So that it's often the onset of mental illness, it's often the onset of substance use, right? So that it's very useful for everybody. But I think that there's actually a really good book that the person who invented cognitive remediation, her name is Alice Medaglia. She's a psychologist. She was out of Montefiore. Now she's head of psychiatric rehab for Columbia. She wrote a book for the State Department of Mental Health for parents about how to teach those cognitive skills. So it's very low tech and it's perfect for case managers, and we will get you that.
Awesome. Thank you.
Sure.
And you said cognitive remediation.
Yeah, you can look it up. So cognitive
I wrote it down,
remediation.
Rhiannon.
Thank you.
The mother of all cognitive remediation. The person who invented it is called Alice Medaglia, Medalia. She's a PhD, and if you look up cognitive remediation and Alice Medaglia, you'll probably find some articles. You'll actually find an article about how to use cognitive remediation in supportive housing, because we set up a lab in one of our housing and it was game changing. But Yale has a really robust cognitive remediation program, but I think there are other ones across Connecticut, and I can find out about those, and we'll get those on the resource thing.
Awesome.
But it's
Thank
been really good for youth. Sorry, I ran over. I'm 3 minutes over. You guys, thank you. We look forward to seeing you in the communities of practice, right? And bring these things there. And we're working on this resource guide, and we will get you something, right? But we want to know how to prioritize it.
Thank you.
Thank you.
Thank you.
To see everybody.
Thanks a lot.
Thank you. Bye.
Thank you.